Parasitic infections. Number 1. Scabies. Contagious parasitic disease of the skin caused by mites or Sarcoptes scabi. Incubation period 2 to 4 weeks. Life cycle: fertilized female mite digs sloping burrow within the epidermis, deposits its eggs, and then dies. Eggs hatch. Nymphs come out to the surface of the skin. Maturation: copulation occurs between males and females, then pregnant females start a new cycle. Modes of infection: direct and indirect. Direct by close contact with human cases. Indirect spread by cloth or bedding. Less important because mites cannot survive for more than few days away from the skin. Predisposing factors: poor hygiene, overcrowding, sexual promiscuity. However, scabies ignores all social and economic barriers, so anyone can contract scabies regardless of age, sex, race, socioeconomic status. Clinical picture: itching, which is most intense at night. Lesions are polymorphic. The characteristic primary lesion is a burrow. Other lesions include furrows, papules, pustules, and scratch marks. Lesions are seen on finger whips, wrist area, medial sides of the forearms, medial aspect of thighs, buttocks, anterior axillary folds, areola, umbilicus, lower abdomen, breast in females, and genitalia in males. You need to know that head, neck, palms, soles, and upper back are spared in healthy adults. Complications: secondary infection, insomnia, exhaustion, acarophobia, abnormal fear of mites and other small insects and worms. Nodular scabies, post-scabitic nodules. These are inflammatory nodules which occur as hypersensitivity reaction to the parasite. Itchy, indurated, rich brown in color, up to 5 mm in diameter. Nodules persist for weeks or months. Even after proper treatment of scabies, post-scabitic nodules are treated by intralesional steroids. Diagnosis of scabies: clinical: nocturnal pruritus, positive family history, morphology and distribution of lesions, whether involved and spared sites. Investigations: dermoscopy, skin biopsy, mite extraction, and examination under the microscope. Special variants: scabies in children and infants, atypical distribution, scalp, head, neck, back, palms, and soles are involved, plus the classical sites. Secondary bacterial infections and eczematous changes commonly occur. If we suspect scabies in an infant, we should examine the mother. Crusted scabies, Norwegian or hyperkeratotic scabies, occurs in immunocompromised, mentally retarded patients. Itching is absent or slight in spite of presence of enormous number of mice. There is generalized erythema and scaling with hyperkeratosis of palms and soles. Differential diagnosis: other causes of erythroderma. Animal scabies, caused by zoonotic species, transmitted from animal to human but not from human to human. Short incubation period. Self-limiting course because zoonotic mites cannot survive in human host. Clinically, articarial wheals and excreted papules are seen instead of burrows in sites of contact with animals such as hands, forearms, and thighs. Treatment: general treatment, treatment of all family members at the same time, disinfection of clothes and beddings. Topical treatment: after hot bath in which skin is thoroughly scrubbed, the scabicide is applied carefully on whole body except for the face and neck. And for example of the scabicides, we have permethrin, 5% cream or lotion applied for 1 night, safe in infants and pregnant females with high cure rate. Sulfur precipitate ointment, 5% for children less than 10 years old and 10% for adults, applied for 5 successive nights, safe in infants and pregnant females, irritant, stains clothes, and malodorous. Benzyl benzoate, 25% emulsion, applied for 3 successive nights, irritant. Gamma benzene hexachloride, 1% lotion, applied for 1 night, irritant and neurotoxic, contraindicated in pregnancy and infancy. Malathion, 0.5% lotion, applied for 1 night. Crotameton, 10% cream or lotion, applied for 5 successive nights, followed by bath 24 hours after the last use, safe in infants, but it's weak antiscabitic, while it's more as an antipruritic. Topical medications can be repeated after 1 week. Systemic treatment: antihelminthics, ivermectin, 200 microgram per kilo, 2 doses with 1 week interval, contraindicated in pregnancy, lactation, and infancy. Antihistaminics alleviate itching. Antibodies if there is secondary infection. Pediculosis, caused by blood-sucking lice. Types of pediculosis: psoriasis pubis, pediculosis capitis, and pediculosis corporis. Psoriasis pubis, it's variable with the degree and promiscuity standards of hygiene. It occurs by sexual contact, clothes or towels. Clinical picture: pruritus, pubic area, lower abdomen, upper thighs and eyelashes, nets stuck to the hair, excreta and blood give brownish spots on the underwear. Complications: secondary infection and eczematization. Treatment: same as scabies. Pediculosis capitis, more in nursery and school children, especially girls. However, it can affect all ages and all social classes. Mode of infestation: shared hats, caps, brushes or combs. Close contact. Clinical picture: pruritus, scalp, nets are firmly attached to the hair by cement substance. Complications: scalp impetigo and occipital adenitis. Treatment: topical treatment, permethrin 1 to 5%. Left for 10 minutes, then rinsed off. Malathion 0.5%, left for 10 hours, then rinsed off. Gamma benzen hexachloride 1%, left for 10 minutes and then rinsed off. Treatment is used once per week for 3 weeks to destroy the nymphs. Mechanical removal: nitpicking with fine-tooth comb. 3% acetic acid may facilitate net removal by dissolving the cement substance which attaches the nets to the hair shaft. Finally, pediculosis corporis increases with neglecting personal hygiene. Mode of infestation: cloth or bedding. Clinical picture: pruritus, back, neck, shoulders, waist areas, eggs on cloth or attached to body hairs. Complications: secondary bacterial infection and treatment same as scabies. Papulosquamous disorders: psoriasis. It's chronic, non-infectious, scaly, erythematous skin disease affecting about 1 to 2% of the population. The disease is recurrent with exacerbations in cold winter months, and in the last decade the disease has been linked to metabolic syndrome. Pathogenesis: it's hyperproliferative disease where there is increased rate of division of the basal cell layer, increasing in the rate of epidermal turnover with decreasing in the epidermal turnover time from 28 days to 7 days. Etiology: it's genetically determined disease mediated by T cells. Predisposing factors include psychogenic factors, endocrinal, pregnancy may precipitate psoriasis, metabolic, hypocalcemia may precipitate pustular psoriasis, infection, hemolytic streptococcal infection may initiate guttate psoriasis, lack of exposure to ultraviolet rays. The disease exacerbates in winter, affecting covered parts and occurs in Scandinavian countries more than tropical areas. Drugs: antihypertensives such as beta blocker, calcium channel blockers, ACE inhibitors, NSAIDs, and antimalarial drugs. Metabolic: we have hypocalcemia, which may precipitate pustular psoriasis. Trauma: the disease usually starts on pressure points as elbows, knees, and sacral areas. Also, trauma elicits disease in uninvolved skin, and this is called Koebner's phenomenon. Clinical picture: primary lesion is well defined, erythematous papule covered by shiny, silvery, dry, loosely attached scales. Papules coalesce to give plaques. Removal of scales leads to appearance of bleeding spots, and it's called Osped's sign. Clinical types: we have psoriasis vulgaris, nail psoriasis, flexural psoriasis, guttate psoriasis, erythrodermic psoriasis, pustular psoriasis, and psoriatic arthritis. Psoriasis vulgaris is the most common type, bilateral, symmetrical, scaly, erythematous papules and plaques, involving extensors of upper and lower limbs, elbows and knees, lumbosacral areas, nails, glands, penis, and scalp. Nail psoriasis: it may occur alone or in association with psoriasis elsewhere. Nails may show pitting, subingual hyperkeratosis, ridges, onycholysis. Multiple nails are usually affected in both hands and feet. Flexural psoriasis involves intertriginous areas, axillae, groins, submammary folds, gluteal folds, and it has the same clinical features, but scaling is reduced and absent due to moisture from friction. Guttate psoriasis: lesions occur as an abrupt eruption following acute infection, particularly streptococcal pharyngitis. Lesions are 2 to 5 mm in diameter, occurring on the trunk, upper and lower limbs. Erythrodermic psoriasis: more than 90% of the body surface area shows erythema and scaling. It might start de novo or on top of psoriasis vulgaris. Pustular psoriasis: sterile pustules are formed. No organism is detected in bacteriological examination, only neutrophils. It may be generalized or localized to palms and soles. Psoriatic arthritis usually affects distal interphalangeal joints of both hands and feet. However, it may involve any joint. Management, reassurance, emotional support, patient and family education. Treatment includes topical and systemic therapies depending on age, sex of the patient, type, and extent of psoriasis. Local therapy, for mild and localized cases, we give coal tar 2 to 5%. It shouldn't be used on the face, genitalia, or flexures, or in pustular psoriasis. It may be followed by ultraviolet rays exposure. Anthraline or dithranol 0.1 to 0.5% effective, but irritant and stains the skin brown. Corticosteroids used for localized areas, and it could be used in ointment, cream, lotion form. Increased effectiveness could be achieved by occlusion with plastic wrap. Salicylic acid 5%. It helps to remove scales. Calcipotriol, vitamin D3 analog. It induces differentiation of keratinocytes and inhibits T cell proliferation. Combined with topical steroids, they give better response. Phototherapy, POVA and NB-UVB. POVA is topical photosensitizer, Suraline with silent P, followed by ultraviolet A rays. NB-UVB is narrow band ultraviolet B. Laser, Eczema 308 nanometer with or pulsed dye laser may help in some cases. Systemic therapy for extensive psoriasis vulgaris, pustular, ristrodermic, or thoracic arthritis. Methotrexate, antimitotic, decreases the rate of basal cell division, given in a dose of 0.2 to 0.4 mg per kilogram per week. Side effects include liver and bone marrow toxicity with teratogenicity. Retinoids, vitamin A derivatives, given in a dose of 0.5 to 1 mg per kilo per day. Side effects include hyperlipidemia, dryness of skin and mucous membranes, teratogenicity. Cyclosporin, potent immunomodulatory agent used primarily for prevention of transplant rejection, given in dose of 3 to 5 mg per kilo per day. Side effects include hypertension and renal toxicity. Photochemotherapy, POVA, systemic photosensitizer, Suraline with silent P, followed by 2 hours of ultraviolet rays A. Lichen planus, pruritic scaly erythematous disease of the skin, mucous membranes, hair, and nails of unknown etiology. Etiology still unknown, however, theories include genetic predisposition, immunological, T-cell mediated disease, psychological stress, many cases are preceded by stress, liver disease, hepatitis C virus, sun rays causing actinic lichen planus, drugs such as antimalarials, gold, and NSAIDs. Clinical types: classic lichen planus, actinic lichen planus, hypertrophic lichen planus, scalp, mucosal, and lichen planus of nails. Of nails, linear ridges, nail thickening, hyperkeratosis, dystrophy, and pterygium. I think it's pterygium. Nail lesions may cause permanent damage of the nail plates. Mucosal lichen planus involves buccal, labial, gingival, and or lingual mucosa. Glans penis and vulval mucosa may be involved, characterized by reticulate white streaks forming network, pinpoint papules, or ulcerative regions. Ulcerative lesions are more painful and develop squamous cell carcinoma, and generally they are resistant to treatment. Scalp lichen planus, hyperkeratotic follicular papules, usually healed by cicatricial alopecia. Hypertrophic lichen planus, lesions are thick, elevated, and extremely pruritic. Actinic lichen planus or lichen planus trophicus occurs on sun-exposed areas, forehead, butterfly area, lower lip, V-shaped area, chest, and dorsum of the hand, characterized by classical papules or annular lesions, with exacerbation in summer and remission in winter. And then we have the classical lichen planus. Primary lesion is well-defined, flat-topped, polyangular, violaceous, itchy papule with shiny surface and fine adherent scales. Lesions usually involve wrists, flanks, medial thighs, ankles, shins of tibia, glans penis, or a mucosa, or may be generalized. Pruritus is paroxysmal, may be severe. Patient responds by rubbing the lesions rather than scratching. Koebner's phenomenon or isomorphic response is present. Characteristic post-inflammatory hyperpigmentation usually occurs after resolution of lesions. Course of the disease. Most lesions undergo spontaneous healing within 6 months to 2 years with post-inflammatory hyperpigmentation, and recurrences may occur. Mucous membrane lesions tend to be chronic. Treatment: topical, systemic, and intralesional corticosteroids for hypertrophic and mucosal lesions. Topical therapy: corticosteroids and sunscreens for actinic. Systemic therapy: antihistamines, corticosteroids, retinoids, and antimalarials for actinic lichen planus. Pityriasis rosea is an erythematous scaly eruption, represents an exanthematous reaction to upper respiratory viral infection. Incidence is highest between 15 and 40 years, more prevalent in spring and autumn. Etiology: human herpes virus 6 and 7 may be involved. Clinical picture: primary lesion, herald patch, single over or rounded lesion, which shows 3 zones: outer erythematous zone, inner paler center with intermediate collarette of scales, usually starts on one side of the trunk with its longitudinal axis parallel to the ribs, involutes within 1 to 2 weeks. Crops of multiple similar but smaller regions develop usually on proximal limbs and trunk, parallel to the ribs, forming Christmas tree pattern. Asymptomatic in most cases, itching may be present, spontaneously healed within 4 to 8 weeks without sequelae. Recurrences are rare. Treatment: reassurance, avoid skin irritation, topical calamine lotion, mild corticosteroids, ultraviolet light B, MB, UVB, systemic antihistamines in case of itching. Then we have connective tissue diseases. Lupus erythematosus, autoimmune collagen disease. It has 3 particular forms: DLE, SCLE, and SLE. Discoid lupus erythematosus, subacute cutaneous lupus erythematosus, and systemic lupus erythematosus. Discoid lupus erythematosus, chronic inflammatory scaly erythematous eruption confined to the skin, occurring in the 3rd and 4th decades. Female to male ratio is 2 to 1. Lesions involve sun-exposed areas: forehead, butterfly area of the face, nose, ears, lower lip, scalp, V-shaped area of chest, and dorsum of the hand, characterized by well-defined erythematous plaques covered by adherent scales. Lying underneath are dilated pilosebaceous orifices, stippling sign. Borders of the plaque show telangiectasia. In the course of several months, it resolves, leaving atrophic or hypertrophic scars. Therefore, scalp lesions end up with permanent cicatricial alopecia. So the 5 cardinal signs are erythema, telangiectasia, scaling, stippling, and scarring. Up to 20% of cases are potential SLE patients. Treatment: avoidance of sun and application of sunscreen creams and lotions. Antimalarials as hydroxychloroquine 200 to 400 mg per day, systemic photoreceptors and anti-inflammatory. Potent topical or intralesional corticosteroids for localized lesions, systemic corticosteroids for resistance and extension. Systemic lupus erythematosus, multisystem disorder, characterized by fever, malaise, arthralgia, involving skin, kidneys, joint CNS, and CVS. Female to male ratio 8 to 1, usually occurring in early adult life and may occur in childhood with high mortality rate. Skin manifestations: livedo reticularis, Raynaud's phenomena, alopecia diffuse and non-cicatricial, purpura, vasculitis, ulcerations, malar rash, erythematous, non-scarring patches on light exposed areas, discoid lesions resembling the discoid lupus erythematosus. Allergic disorders: dermatitis or eczema, itchy dermatosis, characterized by erythema vesiculation in the acute phase, dryness with lichenification in the chronic phase. Clinical stages: acute, chronic, subacute. Subacute is mixture of both acute and chronic forms. Acute primary lesion is vesicle or papulovesicle, characterized by erythema, edema, oozing with subsequent crusting. Chronic dermatitis, prolonged course, repeated attacks leading to lichenification, thickening of the skin, and exaggeration of skin markings, excoriations, hyper or hypopigmentation. Clinical types: contact dermatitis, divided into irritant contact dermatitis and allergic contact dermatitis with photodermatitis. Irritant contact dermatitis caused by direct skin damage due to strong acids and alkalis or cumulative damage by mild irritants. It may occur after exposure to high concentrations or upon repetitive exposure to low concentrations of weaker irritants. It affects any individual. No previous contact is required. Allergic contact dermatitis due to immunological reaction in genetically susceptible individuals after exposure to allergen. Presentation of allergen occurs by Langerhans cells to T cells, type 4 reaction, re-exposure to the same antigen. Lesions develop in sensitized individuals at sites of contact. Common allergens include resins, glues, cleansers, cosmetics, and medications such as sulfa powder, penicillin ointment, and local antihistaminics. Photodermatitis, photoallergic reaction, occurring as a result of activation of a chemical applied on the skin or ingested systemically by light. Lesions appear on light-exposed skin and present with acute eczema. Diagnosis of contact dermatitis, history, clinical picture, histopathology, patch testing for allergic contact dermatitis, calculated amounts of common allergens applied to skin of back, kept for 48 to 72 hours. Eczema develops at sites of causative allergens. Atopic dermatitis, atopy, is a genetic hereditary predisposition to develop bronchial asthma, allergic rhinitis, or atopic dermatitis. Family history is positive in 50 to 70% of the patients. It may develop at any age and may continue from one phase to the other. Precipitating factors, irritants, allergens, excessive washing, staphylococci, viruses, cold weather, lack of humidity. Phases: infantile phase, infantile eczema, starting 2 months of age, presents as acute eczema of cheeks, dorsa of hands and feet, and it may extend to other sites. Childhood phase, groups of itchy papules involving flexures, particularly antecubital fossa and popliteal fossa, with sides of the neck. Lesions tend to be less exudative. Adult phase, lesions are similar to childhood type, associated with hyperpigmentation and lichenification. Stasis dermatitis, caused by chronic venous insufficiency with extravasation of RBCs and deposition of hemosiderin in the derms with subsequent itching and dermatitis. Usually involves medial side of one or both lower limbs with itching, pigmentation, edema, oozing, vesiculation, crusting, and subsequently possible ulceration. Seborrheic dermatitis, scaly erythematous dermatitis, caused by lipophilic yeast, Pityrisporum ovale. It has two distinct forms, infantile and adulthood. Infantile starts as early as 2 weeks after birth. Greasy, yellowish scales occur on the scalp, diaper area, intertriginous folds, such as groins, neck, retroauricular areas, subside spontaneously within few months, may be difficult to differentiate it from atopic dermatitis. Adults affects individuals with genetic susceptibility due to effect of androgens on sebaceous glands. Diffuse or localized scaly erythematous patches involving scalp, nasolabial folds, retroauricular areas, antisternal and interscapular lesions, axilla, and groins. Treatment: general management and according to types. General, local, systemic. Local for acute lesions, drying antiseptic lotion as potassium permanganate 1/8000, aluminum acetate or normal saline, and corticosteroid creams and lotions. For chronic lesions, corticosteroid ointments and moisturizers. Systemic therapy, antihistamines, and short courses of corticosteroids in severe extensive cases. Management of special types. Contact dermatitis, primary irritant dermatitis, avoidance of irritants, protection by gloves, lubrication by emollients. Allergic contact dermatitis, avoidance of known allergens. Atopic dermatitis, education of patient and family, avoidance of dryness, irritants, extremities of temperatures and humidity, application of topical corticosteroids, immunomodulators such as tacrolimus and pimsirolimus, moisturizers and emollients, phototherapy, narrowband ultraviolet B rays in extensive cases, stasis dermatitis, limb elevation, support stockings, management of varicose veins, seborrheic dermatitis, corticosteroids, creams and lotions, antifungal creams, antifungal shampoos containing selenium sulfide, zinc pyrithione, ketoconazole for body and scalp for adult cases, systemic antifungals in severe cases, olive oil for removal of thick crusts in infantile scalp lesions. And this concludes our part for today.